All right, good morning, everyone. Good afternoon, I should say. My name's Prue Walker, and I'm a FASD social worker specialist in FASD. And today we're going to be talking about pathways to diagnosis. I'll just start by acknowledging all of the traditional owners of the lands on which we're meeting today, and I want to pay my respects to elders past and present and extend that respect to Aboriginal and Torres Strait Islander people here today. Just moving things around on my screen. Hey, um, you may have heard about FASD and think that it sounds like your child. You might be wondering if your child has FASD. You might be in a situation where you don't know about prenatal alcohol exposure and whether that's present or not. Or you might have information about that, but you've had trouble getting a pediatrician, or you've got a child who's on a wait list for assessment. So often people are really unsure of what to do next. So I'm hoping that this session is going to help you really clarify those steps and understand what the next step for you could be. So we're going to be talking about what's involved in a FASD diagnosis. So I've worked at a Monash clinic, the VicFAS clinic, for a number of years since it started nearly 7 years ago. And currently I work in a secondary consult service. So we provide advice to other clinicians and to child protection workers about how to go about this. So I'm drawing on what the advice that we give in our clinical practice. For a FASD diagnosis, we need confirmed prenatal alcohol exposure. So we need some confirmation of that. A child needs to have what we call a clinically significant impairment, so a fairly severe impairment, in at least 3 different areas, or what we call domains of brain function. There also needs to be a functional impact. A child can't just score poorly on a test but not show any difficulties in daily life. We need to see evidence that this affects them in their daily life, at home and at school. And there also needs to be no better cause or explanation, no other syndrome or diagnosis or other condition that could explain what we're seeing. For evidence of prenatal alcohol exposure, that's often the stumbling block. We need to have something that confirms that this happened during the period of the pregnancy. It could be in birth records or antenatal records. It could be information from parents or family members. Some of you may be kinship carers who've been able to provide that information yourselves or who might know that. Or it could come from other eyewitnesses or people who knew the parents during the pregnancy. It can also be found in health records and child protection records. So all of these are possible sources. The domains that can be assessed are, there's 9 different domains, and we'll talk a little bit about them. I'm not going to go into giving you a definition of them. I'm more going to talk about who assesses each of these. But there are 9 possible areas that can be assessed, and they can be done by different professionals. You can get a FASD assessment through a specialist multidisciplinary team or through a pediatrician, sometimes a psychologist or psychiatrist who works on their own, who gets input from other people. And that's often the most common way because multidisciplinary teams like VicFAS often have very long waiting times and many children can't wait that long. The paediatrician will do a physical examination, and that's important because there are other syndromes that can cause developmental delays, and they're really well positioned to notice things about children that actually might indicate a different diagnosis. They will assess their facial features, which are sometimes present in FASD, but not very often really, and not very important to the diagnosis. Some paediatricians in the past might have said that, well, there's no physical features, so it can't be FASD, but we know that that's not actually true. They also look for other dysmorphology, that means other changes to the face or body that could be due to alcohol, and any other health issues like, nutrition, all the sorts of other things that they might examine. An occupational therapist or a physiotherapist would assess motor skills, balance and coordination, which all contribute to FASD. They can also do a sensory profile, although that doesn't actually progress the diagnosis, but it is helpful information. A speech pathologist will assess communication in a language assessment. And a psychologist or neuropsychologist can assess some or all of these areas. Intellectual abilities are the ones that we most commonly see. When we talk about a cognitive assessment, we're usually talking about an IQ assessment, and they're the sort of reports that school psychologists would do. Typically with those that also assess adaptive functioning. So that's the Vineland questionnaire most commonly, or the PEDICAT. You might have been asked to fill one of those in for a child in your care at some time. Typically, when they're assessing a child that might have an intellectual disability, they would need to do an IQ assessment and they would need to do an adaptive functioning assessment at school to qualify for an intellectual disability. But school psychologists can also assess academics. Not all of them can assess attention and memory, and executive function tends to be the domain more of neuropsychologists, but it can vary a little bit. So to get to a FASD diagnosis, we need that confirmed prenatal alcohol exposure, the 3 or more areas of impairment. In this case, we've got a child who's got no cognitive difficulties. They might struggle, but they haven't got a significant impairment. But they've got difficulties in their attention, their adaptive function, executive function, and their motor skills, which would have been assessed by that OT. And they need support. These things combined are causing them difficulty. You can imagine this child's going to struggle focusing at school, tying their shoelaces, following routines, and there's no better explanation for what we're seeing. And we end up with an assessment or a diagnostic report that says, yes, this is the diagnosis. So for carers, where do you start? Really, the first thing is a pediatrician. A pediatrician is really central to a diagnosis. Now, there are a number of places you can access pediatricians, and some of you probably know more about this. You've probably been working with pediatricians for a long time, but there are some areas have community pediatric clinics, others have hospital clinics like Monash and Frankston, Dandenong. Some clinics are like general pediatrics and others are more developmental pediatrics, but any pediatrician can progress some of these diagnoses, some of these assessments. You'll be familiar if you've looked after Aboriginal children of some of the clinics. There are some of you may be using private providers, or we know there are some schools that have pediatricians embedded in them. And there's also a fairly newish program, the locals. There are 3 areas in Victoria that have a local service, and they include some allied health assessments and pediatricians. So for prenatal alcohol exposure, a child doesn't need to have this confirmed to be getting referred for these developmental assessments, but it is needed if the child's going to get a diagnosis of FASD. So if you have information about prenatal alcohol exposure, we call it PAE, write down what you know if you have first-hand knowledge. It's usually not enough to say, sometimes we'll read reports that says grandmother says mum used alcohol in pregnancy. We would want to go back to that grandma or have someone speak to her and say, well, were you in contact with the parents during the pregnancy? How often? What did you see? What did you notice? How do you know it was in that time frame? Maybe there's an event that you remember, I was looking after an older child and I remember the pregnancy with the second child. That sort of detail is really important because that provides, it shows that the information is reliable. We can't just generalize and say, someone's, they've always drunk alcohol as long as I've known them. We need to know that there was, that you saw them during that pregnancy period or you had some direct knowledge of it. If other people have the information, it's important to get that documented, and it might be, asking someone to document it or asking someone to review a file. If you might be in contact with a family member who tells you something, it would be good if they would email or write down the details of, in as much detail of what they know. As someone who spends a lot of time reviewing files, I read a lot of reports where pediatrician says someone reports alcohol in pregnancy, and we spend a lot of time going back to where did that come from? Who said it first? Who's the source of the information? And sometimes we see children where they've been going to a pediatrician for quite a long time. And after many years, the issue of alcohol comes up. And I always want to know, well, is this something that has just been remembered or people knew it and didn't think it was important? how come it didn't come up earlier? Doesn't mean it's not correct, but it just helps to understand the context of that. If you don't have the information, you might need to ask professionals for help to gather information, because although you can put in freedom of information requests to places like Child Protection, as a carer, you're not going to get as much information as another health service will. So in Victoria, we have the Child Information Sharing Scheme, and that allows medical providers and allied health, schools, etc., to request information from each other, even without parental consent. In the service I work in, FASD Connect, we do a lot of work helping paediatricians find this information. But it's not information that's going to be sent to you as a non-relative or not, but even if you're the guardian of the child, you wouldn't necessarily be entitled to this. You have to be what's called an information sharing entity, and then they can exchange that information. So we're often able to get information from health providers that families themselves can't get. So paediatricians they've got a range of options. They can refer in to a specialist service like VicFAS, but we have a very long wait time, and the wait list is currently sort of suspended. We do have options for children who are aged 0 to 3 and for Aboriginal children. So it's always worth getting a paediatrician to inquire about that. But the referrals, we can't take inquiries directly from families. We need to hear from the paediatrician themselves. Paediatricians can conduct some assessments. For children under 7, they can assess global developmental delays, which contribute, or they might assess ADHD, and they can also make referrals to some of these allied health providers, especially psychology, speech, and OT. They can reach out to us at FASD Connect to do a secondary consultation. We support clinicians who work with children in care up to age 18. Technically, our program is part of Pathway to Good Health, so we prioritise children who are under current child protection, but we do provide advice to a wide range of paediatricians, and so if a paediatrician wants to contact us, we try not to, we try to provide some support to them. If you're on a wait list for a paediatrician, you might have a GP that can also help you get some of these referrals for assessment in. They might be able to help you locate clinics that are low cost or have free options. And GPs can also refer that younger age group to Monash Health. If you're looking at who to get an allied health assessment from, you're probably all very familiar with this. Those of you who are caring for children who've got OTs or speechies or the range of providers involved. But it could be done by a child's NDIS providers sometimes, not always. Community health clinics with a paediatric focus, private providers, and also university clinics. If you Google, and I've got this on the information sheet, if you Google university clinics paediatric assessment, you'll see a range of universities that have these clinics. You really need to look at each one to see what they do. Some of them just do cognitive, some of them do autism, some of them have a closed wait list, others have a wait list that's open, some of them charge a fee. So it's worth looking into them, and that can change quite often. So I'm not going to put all the details on the information sheet because you really need to check each time. A lot of these closed down in COVID and then they've reopened in different ways. And the Department of Education can also provide cognitive and sometimes speech assessments and sometimes others. Child and adolescent mental health services, some of you may have been involved with these with children or young people in your care, and that can be via self-referral or GP, paediatrician, or you might have turned up to a hospital and come in that way. Depending on the service that you're in, there may be access to cognitive language or neuropsych assessments there. This is really something that they can choose to provide to children under their care where it's indicated. It's not so much that you could get in touch with them for that purpose, but if your child is involved with services like that, it may be one of the options there. So let's say, sometimes a carer might have a child who has an inpatient admission. You might say, look, we've been wanting to get a cognitive assessment done. Is that something that, is in scope here? Because that might help explain some of what we're seeing. When it comes to allied health, psychology, a general psychologist can do cognitive, IQ, adaptive functioning, and academics. I mentioned ADHD can be done by psychology, neuropsych, and by paediatricians. Paediatricians do a shorter assessment than psychology, but both can be effective. Motor skills OT and speech and language by a speech pathologist. And when clinicians are doing these assessments, they're looking at two things. They're looking at what are the child's natural abilities, what are they capable of, or what have they got potential to do? And they're also looking at the functional impact. What can they actually do? I notice this when I'm doing questionnaires with carers and it says, can your child make themselves a snack after school? And sometimes carers will say, well, they could, but they don't. So we would take that as a they don't. That yes, they know how to use a knife and fork. Yes, they can open the fridge, but they don't actually go and get themselves a snack when they're hungry. That might be the least of your problems. They might be very good at getting themselves snacks. But what we would say to clinicians is have a look at the FASD guidelines, have a look at the domains, and try to, as a carer, you might not give your clinicians this advice, but we want clinicians to be looking at the tests that are going to help provide the information needed for a diagnosis. The FASD Guidelines group is providing some training and resources for lots of different practitioners, and this will be coming soon, and I'll put details in the handout. If a young person has basic assessments, usually the ones done first are cognitive, language, and ADHD. And if they have impairments in those areas, that could well be enough to go forward with the FASD diagnosis. So we want paediatricians to have a look at those assessments within a reasonable time frame. So they're still current. You can maybe use a cognitive assessment that's been done for a year or two. We at FASD Connect can help. We sort of teach paediatricians how to do this, and we're available to give them advice. But if the impairments aren't obvious, which is often the case, they don't have a cognitive impairment and they don't have a language delay, then we have to look a bit deeper. And we look at some of the other areas like executive function, attention, which can be ADHD, but we need a bit more information. These kids are more likely to need some extra questionnaires, possibly a neuropsych assessment, or again, consultation with a service like ours, because it needs a bit more interpretation. Sometimes you might have a child assessed and their scores are pretty good and you're like, well, that's not what I'm seeing at home. Maybe they've done well on an assessment, but they can't actually use their skills very well in daily life. We see this a lot in clinic where children can do reasonably well when they have a lot of support and scaffolding, but they can't kind of reproduce that at home. So when children are being assessed, it's really important that clinicians understand FASD and recognise the gap, the importance of seeing what people can actually do in real life settings. Sometimes we'll see that well, the child's, got an impairment at home, but not at school. School says they're fine. Maybe there's lots of reasons why. Maybe their medication wears off when they get home. Maybe they've been holding it in all day. There could be lots of reasons, fatigue. So it's important that not be discounted by clinicians, and really, FASD education is the way that we help them interpret those results. There are some assessments that children have that don't really contribute to FASD diagnostic domains. They can still be useful, but they don't always count. Sometimes carers will say to us, well, they've had all these assessments already. And we might be saying, well, these ones actually don't tell us about their neurodevelopment. They tell us about behaviour or other things, but they don't tell us about their underlying abilities. We really want to know, especially their cognitive abilities and their language abilities. If a child can't process information or language, they're going to struggle with all sorts of things, and we kind of need to know the baseline. So sensory assessments, for example, can be helpful for you to develop strategies, but they don't contribute to a diagnosis. Autism assessments often, particularly when the child doesn't meet criteria, they're not necessarily going to help. They can tell us about social communication. Sometimes children will have screening tools. Now, if someone has a language screening tool and it says they're ticking all the boxes, they're probably not going to have a severe impairment. So although we don't use that, we couldn't use a screening tool to say they did have an impairment, it might tell us that it's really not worth assessing that area any further. We really want to focus on assessing the areas where we see weakness. You might have seen or had children in your care with trauma assessments that look at, lots of reasons for their behaviour. These can be very helpful, particularly for therapists, but they don't tell us about the child's underlying abilities. We really want to know what's their cognitive ability and what's their language and what's their ability to pay attention. Sometimes you have these assessments and a child doesn't meet criteria, even though you maybe feel like they should. Sometimes it's about waiting a bit longer. And sometimes the gap between a child and their peers will get bigger as they get older and the demands on them increase. Some things like IQ scores tend not to change over time, or language scores, but other areas like executive function or adaptive skills, they develop over time, and we often see the gap growing as kids get older. So a child who's assessed at 7 and doesn't meet the criteria, if they've got prenatal alcohol exposure, they need to have that for a diagnosis. You might say they need to be reassessed before they go into high school. And as a carer, you can keep gathering information about, what they do struggle with in daily life. If prenatal alcohol can't be confirmed, this happens. It might be that it happened but there's no evidence, or it might be that it didn't happen and there's another cause that we just don't understand yet. We're looking at, NDIS services are moving away from the diagnosis and more towards a functional impairment. And there might be future tests that are more specific to FASD, but for some families, this is going to be the case. We just can't progress it, and it can feel very frustrating. So what do children need? Regardless of a diagnosis, that children need carers that are tuned into them, who notice what they can't do and make adjustments. They need professionals and allied health professionals who are going to listen and advocate. Children will need individual accommodations and plans at school and home, regardless of diagnosis, and environments where they can succeed. They might need supervision and scaffolding and lots of opportunities to do things that they're good at. And what carers can do is really just keep advocating, keep using supports, work with allied health, use supports like PCAF if you're having trouble finding good providers. You can use FASD strategies even without a diagnosis. They can benefit all children. And educate yourself about FASD and the brain. But a diagnosis doesn't change things overnight. When placements are struggling and carers are struggling, a diagnosis is not always going to resolve things. It's going to help you understand, but it's not a quick fix. It's a long pathway forward, and it can be a good pathway forward, but it's not the only pathway. So I guess I want to reassure carers who feel frustrated if a child they think could have FASD and they can't get any progress with that. If you've tried everything, it may be that it's just not possible. Okay, I'll finish up now. I've gone a little bit over, but I can stay back a bit longer for a few questions, and we'd love it if you would fill in the evaluation, and this will also be emailed to you as well.